Welcome to PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I am Mariana Parks, physical therapist and your host, and today I'll be interviewing Dr. Rodrigo Scattone Silva to discuss his latest paper, Patellar Tendon Load Progression During Rehabilitation Exercises, which was published in the Medicine and Science in Sports and Exercise journal, now in March 2024. In our discussion, we talked about how the loading profile of exercises was evaluated and how the exercises were ranked, examples of exercises with their respective patellar tendon loading index, and how to progress exercises during rehab based on their loading profile, and much more. Dr. Scattone Silva is an associate professor in the physical therapy program at the Federal University of Rio Grande do Norte, Brazil, and he completed his postdoc studies in biomechanics and movement science at the University of Delaware. If this sounds interesting to you, please subscribe to our channel, hit the notification bell for updates, give us a thumbs up, and share with other colleagues who could benefit from this information. Thank you for tuning in, and we hope you enjoy the show. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like Systems for PT, the Do Anything Anytime EMR. Systems for PT develops systems for clinicians so you can focus on your patients. Go to systemsforpt.com to schedule a demo today. Sarah Health. Skeptical? I was too. But with Sarah Health, you will be as pleasantly surprised as I was. They focus on simplicity, no complicated apps for your patients to download, just streamline RTM. Hi Rodrigo, welcome back to PT Pro Talk. How are you today?
Hi Mariana, thanks for having me again. Yeah, I'm doing really well. It's really a pleasure to speak about our research again with you, so I'm looking forward to our conversation.
Yes, I'm excited to have you here so we can discuss all this last study that you had that's with great results, and I think it's going to help a lot our profession. So before we jump right in, just tell us a little bit about yourself and your background for the ones that don't know you and haven't heard our previous episode. Go back and listen to it. It was really good.
Yeah, we were just remembering it's episode 107 if you haven't catched that up. So make sure to go back and listen to that one. So for those who don't know me, my name is Rodrigo Scattone Silva. I'm a physical therapist. I was born and raised here in Brazil. I currently work at a university in the northeast coast of Brazil. I'm an assistant professor here. The university is called Federal University of Rio Grande do Norte. I'm a researcher here. I teach sports physical therapy. I teach orthopedics, and I supervise the clinical rotations of the students in the last year. And I also do research. So I supervise master's degree and Ph.D. students who are interested in doing sports physical therapy research, are interested in tendinopathy, and that's mostly what I do right now. During my Ph.D., I was fortunate enough to go to Australia, and I spent almost a year there studying under Professor Craig Purdam at the Australian Institute of Sport. My PhD was mainly focused on patellar tendinopathy and assessing the biomechanics of jump landings of high-level athletes. And more recently, I went to the United States. I was for 1 year between Philadelphia and Delaware doing research with Professor Karin Silbernagel at the University of Delaware and Professor Josh Baxter at the University of Pennsylvania. So I'm really excited to share some of those results with you today.
Yeah, so let's talk about what were the name and the purpose of your last study.
So this study, the title is Patellar Tendon Load Progression During Rehabilitation Exercises, Implications for the Treatment of Patellar Tendon Injuries. So with this study, what we wanted to see was how much load do we have in the different exercises that we currently do to treat people with patellar tendon pain. How much load do we have in these different exercises? A lot of what we do is based on our critical thinking, our clinical reasoning, our previous experience, but we don't really know how much load we're applying to the tissue. And if we want to be assertive, if we want to progress and build load tolerance in the tissue. It's important for us to have at least a little bit of understanding about how much load we're applying to the tissue. So the main purpose of this one was to evaluate the patellar tendon loading profiles. And by loading profile, we mean the loading index that we created based on the loading peak, the loading impulse, and the loading rate. And we did this on different rehabilitation exercises to develop clinical guidelines to incrementally increase the rate and magnitude of patellar tendon loading during rehabilitation. So this was the purpose of the study. And like I said, the purpose was to provide clinicians with a general overview of how much load we are applying to the exercises that we routinely use in our everyday practice.
Very good. And so the question is, how do we evaluate that profile of exercises in the loading index?
Yeah, that's a great question. I get asked that a lot. So
it sounds complicated. Reading the paper, I was like, well, that one's going to be hard to explain. So
I'm going to try to be as clear as possible on that. So we did a very fancy biomechanical assessment, and we do that a lot in the lab. So we measure several things: kinematics, kinetics, EMG. We measure movement using inertial sensors. And for the everyday clinician, you look at all those numbers and say, what the hell is this? So we wanted to come up with a single number. So if the clinician would have one single number that would tell him a lot about the exercise, what would that number be? So mainly what we did was we measured the forces on the knee joint using what we call the moment arm of the patellar tendon and also the knee extensor moment. What's the knee extensor moment? So when you jump and you land from a jump, you have the ground reaction force. The ground is hitting you back. When you have that ground reaction force, that force is going to be dissipated somewhere. And then you have the movements in relation to the axis of rotation of the joints, and how, depending on how far the force is in relation to the axis of the joint, you have more force in that joint. And then when we multiplied the moment arm of the patellar tendon by the knee extensor moment, the force that was actually being applied to the quadriceps, we actually are able to calculate how much force is being applied to the tendon itself. So we know how much rotator force, the torque, how much torque is being generated in the tendon. And with that, we can know how much the different exercises are actually demanding of that tissue. But we know that tendons are viscoelastic tissues. So it's not just the peak force that matters to us. We also are interested in the time under tension, in how much cumulative force the tendon is actually receiving during the exercise, and also the loading rate. So let me just try to explain this really quickly. So the peak force is very important. So I landed from a jump. What's the highest force that we have? So we saw around 7-8 times the body weight being achieved in some of these exercises. So that's a lot. If you think about when you land from a jump, you have like 5 times, 6 times your body weight being applied to your tissue. That's a lot of force for a small tissue. But sometimes you look at a curve of the force and you see a very high peak, but then the force goes right down. You have a very small window of load in that specific moment. So you don't have a lot of force. You have a very high intensity, but the duration of the force is very small. That's what we have when you jump. But when you perform a very slow squat, you may have a lower peak, but the duration of the load is very long. So you have a lot more force being applied in the total load that's being applied to the tissue. So we didn't just wanted the peak force to provide clinicians. That would be much easier, but we wanted to actually take into consideration all of these variables. So we used the peak, the highest force that was applied. We also calculated the area under the curve of a graph that has on the y-axis the force, in the x-axis the time, and then you have the whole curve of the loading of the exercise. And we calculated the area under the curve so we could see the cumulative force that was provided during that exercise. And then we also did the calculation of the loading rate, which is how fast the load is being applied to the tissue. Because like I said, tendons are viscoelastic, so they're rate dependent. Loading rate dependent. If you make an analogy with playing dough, you're pulling the playing dough very slowly, it will give in, it will stretch. But if you do the same thing very quickly, you will see that the plane though will rupture because you did that very quickly. So tendons are the same. If you do something very slowly but with a high load, they will stretch, they will strain. But if you do a very high velocity load, they may rupture. So we wanted to consider everything during our loading index, the loading peak, the loading cumulative force in terms of loading impulse, and also we wanted to consider our loading rate. So we would take into consideration the velocity of the load. I spoke a lot. Let me just try to summarize everything that we did. So we took the loading peak, we took the loading impulse, we took also the loading rates, and we came up with one single number that takes into consideration everything, and we called it the loading index. And then this loading index goes from 0 to 1, with 1 being the highest and 0 being the lowest. And then we ranked the exercises from low to high load so that we could actually organize them in a way that we could provide exercises to patients with a progressive loading characteristics.
Okay, great explanation, very detailed. And how were the exercise ranked?
Okay, so just before that, we did 35 different exercises. And the way we chose these exercises was we looked into everything that was being done in the world in terms of rehabilitation for patellar tendinopathy, ruptures, and also ACL reconstruction rehab after using the bone patellar tendon bone graft. Because what we see very often in the clinic is the patients, after they get their ACL reconstruction using their patellar tendon as the graft, is that they develop patellar tendon pain. We are working with their quadriceps during rehab, and we see that they sometimes evolve with knee pain, specifically in the patellar tendon, which is the donor area. And we wanted to see the exercises that they're doing in rehab after ACL reconstruction to also see where they would fit in relation to the other exercises. So we looked into the literature, we looked into what was being done in the Australia group, the European group, Spain and the Netherlands, in the US, in Brazil. We looked into what was being done all over the world so we could select exercises that would be meaningful to clinicians because they are doing that very often, because they see those in the guidelines and so on. So we came up with 35 exercises. Professor Karin Silbernagel was very skillful in actually helping me trim. I wanted to do everything. I wanted to do 50 exercises. She said, no, we don't have time for that. You're going to kill the participant if you do that. And she was right, because I was one of the volunteers for the pilots, and it was really exhausting to do everything. So we came up with 35. We came up with 35 exercises, and we decided to do them to see how much load we have in the different exercises. And then after we came up with the tiers, with the different, we ranked them from 0 to 1 using the loading index. So one single number that would represent both the loading peak, the loading impulse, and the loading rates. We ranked them from 0 to 1, so from lowest to highest. And then we divided them into 3 tiers. So from 0 to 0.33, it would be tier 1. From 0.34 to 0.66 would be tier 2. And everything above 0.67 would be considered a tier 3 exercise. So we have a low load, moderate load, and high load exercises for the patellar tendon. Does that make sense?
Yes. And so let's talk about what exercises that were considered tier 1.
Okay, so we weren't really all that surprised when we looked into the exercises, because it kind of makes sense to see how much load these exercises are providing the tissue. But we found that specifically for a tier 1, we found that walking at your self-selected pace was the exercise with the least amount of load. After that, we had the low step up. So we did a step up from 10 centimeters box, so about 4 inches. So the person would climb the step, and that was the second exercise. Then we had the double leg squat, 60 degrees of range of motion. So the person would squat down to 60 degrees and come back. Then we have the low step down, so stepping down from a box of 4 inches. And then we had the high step up. So the box was now higher. It was 8 inches, 20 centimeters, and the person would have to climb that step. So those were the 5 exercises that were ranked as tier 1, the exercises that provide the least amount of load to the tendon.
Very good. Not that many exercises. I know tier 2 was the one that had most of the exercises. Do you want to highlight the ones that are tier 2?
Yeah, I'm going to highlight some of the most important ones. Yeah, but that's interesting because we now we have a large variety of exercises that we can do, and this is very important for adherence to the intervention. So we know that adherence is a big problem. A lot of people don't want to keep doing the same thing over and over again. So if we know that a lot of different exercises provide a very similar amount of load to the tissue, we can make our treatment session a lot more diverse. We can provide different kinds of stimulus to the tissue with a wide variety of exercises, and we're providing progressive load to the tissue. So this, for us, was sort of surprising, but in a very good way, because now this gives us a large number of options of exercises. But just to give you a few examples of exercises that we had as tier 2 exercises, we have the Bulgarian squat, which, for those of you who are not familiar with this, is you have a box in the back or a bench or anything that keeps your back leg elevated, and you perform a lunge. So you squat down, you perform a sort of a squat, but using a lunge squat, but using the back leg elevated. So this was the Bulgarian squat. We also saw that the sumo squat was in the tier 2. So that's the squat that you perform with your feet pointed outwards. So that was also tier 2. We found that double leg, before that, the single leg squat, just 60 degrees, was also in tier 2. Double leg squat, full range of motion, was also here. The lunge. And then we had some jumps. So jumping from a box, the drop vertical jump bilateral was also here. Running was on the second tier, but it was much higher. It was one of the highest ones in the tier 2. We had the counter movement jump here, so you jump as high as possible with both legs. We had the single leg drop jump, dropping from the box. We had the running and stop. So you come running and then you stop abruptly. This was also tier 2. And also the Spanish squat. So it's an exercise that has been done a lot to rehab patients with patellar tendinopathy, isometric exercise. So you have a inelastic belt around your tibia, your proximal tibia, and then you just squat down to 90 degrees of knee flexion with 90 degrees of hip flexion. Your trunk is very upright, and you keep that position for a period of time, doing a very high intensity isometric contraction for your quadriceps. So this was also tier 2. So we found a big variety of exercises, different squats, a few jumps. They were all in tier 2. And the highest exercise from tier 2 was running. So this is actually interesting for us, because we know if the patient is tolerating running well, he's running without any kind of pain, this means that he's tolerating that amount of load. So this means I can work with all these exercises from tier 2, and I shouldn't be too concerned about these exercises being too aggressive for the patient in that specific moment.
Yeah, I think that's great, like to help therapists also prescribe the exercise without being fearful or, not being sure if that's appropriate load, and give them plenty of options on like how to progress. As you said, there are so many different exercises that are listed there, and now you know which ones that create more load for the tendon or not. So you can just go through them and vary them, and not be afraid of like prescribing them, because sometimes we just don't know. So it's just so good to have the guidance. So I think that was super important.
Yeah, wonderful. So I guess that was the idea. The idea was to actually help clinicians see how they can choose the different exercises based on how much load they're applying to the tissue for their specific patients.
And let's go to tier 3 then. Just I know
Wonderful.
There are not that many on tier 3.
we have 5 or 6 exercises too in tier 3. So we have the single leg maximal forward hop. So similar to a hop test, when you jump forward as far as possible with one leg. Repeated forward hops, not so fast. So if you jump forward with one leg, but not at a very high velocity, we found that actually generates more load in the patellar tendon than if you do that fast. And that actually makes sense, because if you do that fast with just one leg, you're using the Achilles tendon more. You're using your ankle more to generate power. But if you do it more slowly, you're bending your knee more. So you use your knee more. So we actually did jumps at different velocities, slow velocity jump and high velocity jump. And we found that if you jump a little bit slower, but repeatedly, this actually generates more load in the patellar tendon. The next one was the counter movement jump with just one leg. So if you bend your knee and then do a maximal vertical jump and then land, this is a very high load exercise for the patellar tendon. The change of direction, so we call this run and cut. So if you come running as fast as possible and then make a 45-degree cut to your left, using your right leg as a support leg. So that is a very high load exercise for your patellar tendon. And the last one was kind of surprising, but not so much, was the single leg decline squat. So the single leg decline squat, let me just repeat that to you, is the exercise with the highest load index for the patellar tendon. And that was, like I said, kind of surprising, but not so much, because it's an exercise that is designed to actually isolate the quadriceps the most. You put the patient with the foot in plantar flexion, so you generate a shortening of the ankle plantar flexors. So you put them into insufficiency. And you actually keep your trunk as upright as possible. So you take away the glutes from the squat. You're basically squatting only using your quads. And we found that this exercise has a very, very high loading peak and also a very, very high loading impulse. So thinking about an exercise that has a very, very high load for the patellar tendon, this one would be something that would make sense to be used in the advanced stages of the rehab, but not so much in the initial stages.
And that was going to be my next question, because I was reading about it, and it seems like a lot of people, a lot of clinicians use it at the beginning of the rehab, right? And that it's according to your study on like all these loads, so that would not be appropriate to start a rehab like that. Is that correct, that line of thought? Like, what are your thoughts on that?
Yeah, so we didn't actually assess patients in this one. It was only healthy people. So we have to make that clear. It's one limitation of the study. But having said that, physics always applies. So if you have a mass that's jumping, if you have a mass that is squatting, the ground reaction force is always there. So one thing that people sometimes ask, but do you think patients will behave the same? And I actually saw the results from somebody who actually did something similar to what we did, and they compare patients with healthy people. And the correlation was almost perfect. The loading was very, very similar. So because you're providing them with instructions to do an exercise, and then they're doing the exercise. So even if they have pain, they're trying to do that the same way that a healthy person would do. So having said that, should we be using the single leg decline squat as the first exercise? And my answer would be a very strong no. And that's kind of counterintuitive, because if you look into a clinician that is just looking for the literature and he doesn't have any idea how to treat a patellar tendinopathy patient, and assuming that he would be evidence-based, he would be evidence-based, he would look for the evidence, and he would go into a searching base, go to PubMed, and he would search, and then he would look into systematic reviews, and he would see that there's a vast number of studies doing progressive loading for the patellar tendon using the single leg decline squat. So the single leg decline squat protocol involves you do 3 sets of 15 every day, twice a day, in the single leg decline board, using a backpack with weights, progressively increasing those weights. But again, if our premise of treatment is to gradually progress the load in the tendon, to increase the load progressively so that we can actually increase the tolerance of that tissue, would it make sense for you to start with the exercise that provides the highest amount of load? It's actually used nowadays by most experts in the world as a provocative test, not as a rehab exercise anymore. So we use that as diagnostic. We use that as something to assess how the patient reacted to the exercise that we provided them in the day before. So we assess them to see, provoking the tissue, how much pain do they have. But we don't use that for rehab anymore. But when you look at the literature, because that was used for so many decades as the primary exercise, you're going to look into the systematic reviews and you're going to see people recommending that as the intervention. But if you ask the biggest experts in the world, that's not what they do, because that has changed, but it will take years, maybe even a decade, before the systematic reviews are actually able to capture that change. So I guess that was a very long answer to say, if it's what with my patient, we don't use that anymore. We use the vast majority of exercises that would be on tier 1 and tier 2 in the beginning, and then only in the really advanced stages we would think about using the high load exercises.
And I think that it could be confusing because of the eccentric component, that when people think about tendon rehab, everybody talks about eccentric, that, I think at least like what you learn in college and maybe not keeping up with what's going on currently, but that thought that the eccentric, you should do eccentric. So I think that plays a part probably on why the exercise is being prescribed for so long. Is that a fair assumption?
Yeah, it is. And that's part of the history of the rehab that we have. And back in the day, it was the best that we had. So the eccentric protocol was created in 1998 by Håkan Alfredsson for the Achilles, the most famous one. It goes before that. Even in 1986, we have one study talking about eccentrics from Stanish and Kerwin. But when you look into the most famous protocol, it comes from Alfredsson in 1998, and then that's for the Achilles. And then 2004, you have the first protocol that was done for the patellar tendon using the decline board. And back in the day, we thought that eccentric exercise was more effective to treat patients. But when we saw the literature advance, we saw it wasn't the type of contraction that was important. It was just that the eccentric, when you compare eccentric with concentric, with the same load, the eccentric actually generates more load in the tendon because it's stretching the tissue. It actually allows the tissue to withstand more load than the concentric contraction. But what we know now is that the tendon doesn't understand the difference between the contraction type. It just understands load. So if you provide a slow eccentric, then slow concentric exercise, you have the same benefits than if you just do an eccentric exercise. So the message is there's no convincing evidence to isolate the eccentric components to have the benefits for a patient with tendinopathy. That's what we know now. So now we recommend slow concentric eccentric exercises with progressive load. That's what we know is the best available treatment for patients with patellar tendinopathy, with tendinopathy in general, actually.
Mm-hmm. And how about using the single leg decline squat as a preventive exercise with athletes?
Yeah, that's also a big controversy because back in the day, we used to think, well, if you want to prepare the tissue to be really robust and not susceptible to developing tendinopathy, wouldn't it make sense to provide an exercise program that would actually prepare them not to be susceptible to overuse? And then there was one study that actually tried to do that with soccer players. They took soccer players that were playing in a competitive season, and they gave them a progressive eccentric loading protocol as a prevention protocol. So these people didn't have any pain, and they assessed using ultrasound the patellar tendon of everybody before the beginning of the study. And then they followed up these people to see if they were actually able to decrease the incidence of patellar tendinopathy during the season. And the results were really surprising because they actually observed the opposite. The people who performed the progressive loading exercise using the eccentric decline squat while they were training their competitive season, they were competing, they were training, they actually developed tendinopathy. Instead of being protected from the condition, they actually developed the condition. And that's actually interesting, but it also makes sense because the eccentric protocol is actually prescribed as something that you do every day, twice a day. And then if you do that every day, twice a day, and you also continue training, you continue running, you continue jumping, changing direction, it's too much load for your tissue. You're not allowing your tissue to recover from the high intensity exercise that you're doing. You don't give it enough rest for the collagen turnover to happen. In the molecular level, you actually need the tissue to have some time of rest so that it can actually produce more collagen. Then you have degradation of the collagen that has been there before. So you need at least 36 hours of rest between a high intensity exercise. That's what we know now. So if you don't provide that, you're actually favoring the degradation of the tissue in relation to the actually strengthening up that specific tissue.
Very interesting. And what are your thoughts on using the Spanish squat that it's recommended many times in the initial stages of rehab?
Yeah, the Spanish squat is a good exercise. I mean, of course, you have to be careful with some patients. You shouldn't be doing this with your ACL patients, for example, because they would be having a lot of force of anterior translation of your tibia. So it wouldn't make sense to do that with those patients. But for patellar tendinopathy, there are some very good quality studies showing that it has the benefits. It's a very good exercise to do on the road because the patients don't have any access to a gym sometimes. And to do the Spanish squat, all you need is a belt, or even you can even do it in the wall. It's not ideal, but you can also do it in the wall. So you have a very accessible exercise that you can do pretty much anywhere. It's an isometric exercise. There was a big hype with isometrics a few years back. We saw that it's not really about the contraction type. It's exercise, it's load, it's progressive load that matters. We saw that the Spanish squat is somewhere in the middle of our graph here, is very, very close to the middle of the graph in terms of comparison of the different exercises. So I wouldn't, that's not what I use in the initial stages anymore. It was when I started reading papers on isometrics in 2015, 2016. But now that we know that we have a large variety of exercises that can be done in the beginning that have a little bit less load and that can be performed at home as well, like a double squat, 60-degree double squat, then you can progress the load on that. And then you can do a full squat. You can progress to a single leg squat. And then only then you can go into the amount of load that the Spanish squat will provide the tissue. So in my opinion, now knowing how much load you have in the different exercises, you have a huge arsenal of tools that you can use in your rehab. So it doesn't really make sense for you to just choose one exercise and prescribe only that exercise as your loading protocol. I mean, there's a whole world of exercises that you can use to provide a variety of stimulus to your tissue.
And do you have a general recommendation for clinicians on how to progress load with their patients after looking at all the exercises? Is there any tips on how to think about progressing loads in general terms?
Yeah, that's a great question. And I of course, with our study design, we have to be careful with recommendations for actual patients. I mean, the next step, of course, after this initial step is to come up with a loading protocol using we're already doing that, using these information that we have now. How can we do this and apply it to patients and compare this exercise program with a general exercise program that we already have and see if that actually makes sense, if it's just as effective, if it's more effective. So what we're doing right now is looking into how to apply this to patients, but looking into the numbers that we have and knowing that patients have a very similar behavior in terms of load in relation to the healthies that we saw here. What we can do is, and that's what we are recommending based on what we're looking into the exercises, is you can start with a double leg squat up to 60 degrees. This would be the initial go-to exercise that I would do. After that, you can do either the sumo squat or the Bulgarian squat. They both provided the exact same loading index. The curve is a little bit different. One is a little bit longer than the other, but the loading index was exactly the same. So either sumo squat, Bulgarian squat, you choose, see what fits best to your patient. Then you have the single leg decline, the single leg squat up to 60 degrees. So this is in the floor. It's not the single leg decline. It's a single leg squat up to 60 degrees. And then you progress to the full range of motion double leg squat. And this was also interesting because I would assume that you would progress before in terms of range of motion in the double leg squat before you go to single leg. But we found that the single leg squat up to 60 degrees provides less load than the double leg squat full range of motion. So again, first would be double leg squat up to 60 degrees, then sumo squat or Bulgarian squat. They both provide the same amount of load. Then the single leg squat up to 60 degrees, and then progress to the double leg full squat, full range of motion. Then we would go to the Spanish squat, which is higher load in relation to the exercises that I mentioned before. And then after that, the single leg squat in full range of motion. And then only after all of these have been well tolerated, well progressed in terms of load, then we would do the single leg decline squat in the final stages of rehab, alongside the jumping exercises that would come up, alongside different landings, different kinds of running and changing of direction, deceleration. All of these would be high intensity loads, which would be in the final stages of rehab. But for the initial stages, we have a nice variety of exercises that we can use now.
Very interesting. And to go from double leg to single leg, as you said, I think that was a good observation, that sometimes we automatically assume that single leg is going to have more load than double leg, but it's just thanks to the study. Thank you for letting us know that. And any considerations for the jumping and landing? There are some that I remember, I guess they were in tier 2 and then others on tier 3. Any considerations on that?
Yeah, so landing and running and changing of direction, all of this provides the tissue with what we call a high loading rate. The velocity of the loading that is applied to the tissue is very high. So if we remember the tissues on the tendon are viscoelastic, we have to keep in mind that in the beginning, we should be using low velocity exercises, because that's what is going to give the stimulus that the tissue needs to have a higher turnover, a higher adaptation to the load that is being provided to it. After we have a not so much symptomatic patient in our hand, they're tolerating the high load exercise with slow velocity very well, we start to implement the high velocity exercises in the intermediate stages of rehab, and of course in the advanced stages of rehab. So that's when your plyometrics are going to come in. That's when your landing from a box will come in, landing from a box and doing a double leg vertical jump. Same thing with the single leg. So you do just the landing, then you do the landing and vertical jump after that. We saw that the load is different. So for just the drop jump is lower, drop with vertical jump is higher. The counter movement jumps also are higher than just doing a drop jump. So having that kind of information actually allows you to choose which exercises to use in the initial stages, which exercises to use in the advanced stages, not only for your tendinopathy, but also for your ruptures. For ruptures, this is very, very helpful too, because after a rupture, the patient doesn't have pain. So you can't really use pain as a guide to see, I can actually do this exercise. The patient is completely pain-free. If you do it too fast, it's over. You rupture again. So if you know how much load you have in the different exercises, you can actually have a plan of how to progressively increase the tolerance of load in those patients. And for the ACL patients specifically, I would bring the recommendation of keeping in mind that the single leg forward hop was one of the exercises in tier 3. It was one of the highest load exercises that we found for the patellar tendon. So think about your patients who are ACL reconstructed using your bone patellar tendon bone graft, who are in the rehab. They're not tolerating exercise all that well, and you're doing a hop test for distance to see how well they're doing. You're providing that tissue that's still healing with a very, very high amount of load, very high rate of load. So it doesn't really make sense to do that in the initial, even in the intermediate stages of rehab. So keeping that in mind seems to also be very important for those patients.
And also, like the patellar tendon force can be different on the landing according to the trunk position, right? That's something that you mentioned on that paper too, that I think was very interesting to think
Yeah,
about that.
that's something that we studied before too. In my PhD in Australia, we did a study looking into that, how much the trunk flexion actually influences the load in the patellar tendon. So if you haven't listened to our previous podcast, take a look at that. We go into that in more depth. But just to give a brief explanation on that here, we now know that the trunk position influences the knee forces a lot. So it's where your center of mass is where the biggest amount of your mass is concentrated, your arms, your head, and your trunk. So if you land with your trunk very upright, you have a very high patellar tendon force because your glutes are not working as well to dissipate the landing force, and your knee is working a lot to dissipate that force. Whereas if you land with a little bit of trunk flexion, and that's a little bit, you don't really have to do a really land and then just do 90 degrees of trunk flexion. This doesn't make sense. But if you land doing 10, 15 degrees of trunk flexion and you project your hips backward, you can have a substantial decrease in your patellar tendon force. We saw almost 1 time your body weight being decreased in your patellar tendon force just by bending your trunk a little bit. Just with verbal instructions to increase your trunk flexion, project your hips backward when you land, substantial decrease in your patellar tendon force. So that's something for you to keep in mind. If you want to decrease the excessive load in the tissue in the beginning, it would make sense to teach people to land from a jump using a hip strategy, projecting their hips back, a little bit more trunk flexion. In the more advanced stages of rehab, you actually want them to be able to tolerate the landing with the trunk upright. So you would progressively keep that in mind. You would keep that in mind to progressively increase the load by increasing the upright trunk position in the advanced stages of rehab.
Yeah, and that's super important to take that into consideration when you are giving them jumps and prescribing them all these exercises. And I was going to say the same, go back and check our episode that we talk a lot about that. Rodrigo, anything else before we wrap up this discussion about the paper? Anything that I'm forgetting that's important?
I just wanted to really acknowledge the contribution of Professor Karin Silbernagel and Professor Josh Baxter at the University of Pennsylvania and University of Delaware on helping me come up with this loading tiers, the loading exercises that we came up with, the different exercises that we came up with, and processing this mountain of data that we had to actually come up with one number that would help clinicians to actually be able to progress the load in the patellar tendon of their patients. But one final thing that I would say is, in the paper, we also have a supplementary material, which is a spreadsheet that actually has all exercises ranked the way that we rank them, but then you can actually play with that. You can edit the spreadsheet by actually changing the weights of the loading peak, the loading impulse, and the loading rates. So for instance, if your patient has a rupture and you are very concerned about the loading rates, you can actually give the loading rate more importance in the creation of the loading index. So that way you have the order of exercises that are going to change now because you're going to have the loading rate as the more important variable in the loading index. So the clinician can actually download that and he can actually play with the variables, giving more weight to whatever he or she feels is important to the patient in front of them, so that he can actually provide exercises that are going to be more important in terms of progressing the load tolerance of the patient in front of them.
What an awesome tool. Very nice. And I was just kind of curiosity. So, like, did you come up with all these calculations and these numbers?
No. The credit belongs to everybody who came up before me. So we used the literature to calculate the moment arms. We used inverse dynamics that comes from biomechanists that have been doing this for ages. Of course, we have this shoulder of giants to stand on, and I was fortunate enough to have a fantastic group of biomechanists in the University of Pennsylvania. So Josh Baxter, Kay Song, and Todd Holfish were the soldiers who actually helped us to process this mountain of data. They are specialists in biomechanics, so they made our job very easy. Karin and I are clinicians. We work with patients. We see patients. We come up with ideas. The exercises came from our head. The biomechanists helped us a lot in doing that kind of processing of the data. But I would actually finish with that. So for researchers out there that are listening to us, this is a fantastic partnership. If you have clinicians who see patients very often, see patients every week, coming up with questions from everyday practice, and you pair that up with biomechanists who are specialized in doing amazing calculations, doing very well elaborated studies using the biomechanical tools that we have, kinematics, kinetics, EMG, everything else, you have the perfect match, because you have two worlds that are being brought together to actually bring clinicians with information that are clinically relevant to them to treat their patients.
Yeah. And for the clinicians that are interested in taking a look at the paper, it was published recently, right?
Yeah, it just came out. It was published in 2024, I think in May or March. It's just about to come out. It was published in the journal that is called the Medicine and Science in Sports and Exercise. It's one of the biggest ranked journals in the world in the field. So very proud of that publication. You can check out the whole paper. You can check out the spreadsheet that comes with it. We also have a supplementary material that is the description of every single exercise that we did with pictures. You can see what we did, the instructions that we gave them, the pictures of them doing the exercises. So it will help you a lot to actually be able to apply that in your practice.
That's awesome. Rodrigo, if people want to find you or connect with you or contact you, is there any way that they can do so?
Sure, yeah. So I have been active on social media, mostly in Portuguese. So if you're interested in learning Portuguese, that's your chance of learning more. But you can also use the translation tools of Instagram. It's very good. You can just click on translate. You can see everything there. I'm very passionate about knowledge translation. So we're trying to, every time that we publish anything, we're trying to come up with infographics and ways to bridge the gap between the academia and the clinical practice. So I've been posting a lot of on Instagram. You can find me at R Scattone, my last name. I'm also on Twitter at Scattone Silva. You can find me there. Every time we publish anything new, I'm always sharing the new paper, the anything new that we're publishing is going to be publicized in my social media. So if you want to connect, reach out to me there.
Awesome. Rodrigo, thank you so much for coming back here, sharing this amazing study that you just published. So I appreciate you and your time, and thank you for all the effort putting into publishing this paper, which is so helpful for our profession. So I just want to thank you again.
Thank you. Thank you for having me. It was great coming back and share these results with you. And I hope to do this again with you soon. Thank you.